really great opportunities.
That's great. Right. I think we can ask Dr. Garima to start.
Yes, sure.
Ma'am, should I start? Okay,
Sure,
ma'am.
Sure.
Okay.
Mr. Ruchir, can we go ahead?
We can go ahead.
Great opportunity.
We can go ahead now.
Okay, ma'am. Good evening, everyone. Myself, Dr. Garima Bakka. I'm Associate Professor in OBGY Department in GMC Gondia. I welcome you all to the Postgraduate Star Series number 9, which is all about the fibroids. I'm also thankful to NOJS, Nagpur Society, Dr. Sushma ma'am, Dr. Rajshri Patil ma'am, my HOD, for giving me the opportunity to be the part of this webinar. All about fibroids, as we all know, in majority of patients in our OPD are of fibroids, and incidence in gynec OPD for infertility, for bleeding is very, very high. So, it will be a very great learning today. So I just ask Sushma ma'am to continue further.
Okay. Hello, friends. A very good evening to all. Respected seniors and friends and my all budding PG friends. It gives me today strong and courageous vibes to welcome you all for the 9th webinar of our PG Star Series of Nagpur OBGYN Society in association with Government Medical College, Gondia. Thanks to Dr. Rajshri Patil. I always think to deal with the fibroids will require a warrior-like approach. Fibroids, because sometimes they are silent, sometimes violent, sometimes getting worse and behave like a curse. And we have to tackle this unpredictable behavior enemy with passion, patience, and persistence, with fighting spirit. So Dr. Mayuri Bhagat, a budding gynec warrior, decided to deal all the consequences of fibroids like AUV. She is going to defend her case. And 2 commanders in force, Dr. Swati Shirarkar and Dr. Surekha Taide. They are always geared up with all astras to control the situation. They will govern and teach when and how to use astra and new techniques. Welcome examiners, Dr. Swati Shirarkar and Dr. Surekha Taide and Dr. Mayuri. But whether we can prevent these problems and disasters while managing this, so we need to have a correct and perfect mapping with ultrasound. Yes, Dr. Divya Singh, a genius scanner, will tactfully and skillfully scan the uterus to know the exact situation, location, and nuisance of the fibroid namak enemy, so that all the warriors will get the clue. So welcome, Dr. Divya Singh. Now, Dr. Rajshri Patil and Dr. Allad Mohite, 2 brilliant, great Senapatis, will judge the pre-war situation to plan the modus operandi. Welcome, Dr. Rajshri Patil and Dr. Allad Mohite. Dr. Garima Arora will be governing all the strategies of war and putting in front of all the current updates.
Thank you.
Also welcome audience, respected seniors and friends, and our war discipline strategy conveners, Dr. Anuja Bhalerao, Dr. Bhakti Gurjar, and Dr. Prachi Dikshit. They are very vigilant always. And, really daredevil warriors to always face any situation and to becoming under control. So also, this is also, they are having the very fine, all the PG students becoming protecting as a yodhas. And our NOJS Secretary, Dr. Pragati Khadkar, is really very much geared up to deal with all these different enemy strategies and situations, because she is working on that also. So I think let us learn all the strategies and learn all about fibroids. Thank you.
Ma'am, I invite our first examiner, Professor Surekha Taide ma'am. She is our first examiner and she basically needs no introduction. She is well-known personality to all, but in a very short, she is professor and in unit head in JNMC Medical College, Savangi. She is a teacher, trainer, guide, mentor since 20 years. She is a member of all the societies, endocrine, menopause, and all POXI in all societies. She is a chairperson, Global Women Health Task Force She is a core faculty of Veera project. She is a founding member and vice chair for the future Women in Health Together for the Future. She is a national mentor, quality improvement Lakshya program. She is master trainer for EMOP, critical care in obstetrics. She is expert committee member and she's a co-leader for maternal near miss project. She's a co-leader for maternal death audit project. She has about 108 various national and international projects. She has written many chapters and books publication, reviewer of international journals, and national faculty of FOXY, past president and secretary of Sevagram Society. She works in community on violence against women. She is a member of board of studies in MUHS and various universities, and she is a winner of award like Savitri Bai Phule and Dr. Anand Jimne Award. I welcome you, ma'am.
Thank you.
Ma'am, now I invite our second examiner, Dr. Swati Shiratkar, ma'am. She is professor in Department of OBGYN, MGM Medical College, Aurangabad. She has a professional experience of 34 years and worked as head of the department for about 22 years. She has various publications around 36 and 150 guest lectures to her credit. She is a well-known motivational speaker and her special area of interest is holistic sexuality education for adolescent and youth. And she was past president of AOGS. I welcome you, ma'am.
Thank you.
Now I want to introduce our presenter, Dr. Mayuri Bhagat, who is a second year postgraduate student in OBGYN department in GMC Gondia. Dr. Mayuri could start the case.
Good evening, everyone. I'm Dr. Mayuri Bhagat, JR2 from GMC Gondia. Today I'm here to present the case on abnormal uterine bleeding, EO myoma. Shall I start the case, ma'am?
Yes, please go ahead.
Yes. Yes.
Mrs. XYZ, 41-year-old female, married since 15 years, came with the chief complaint of heavy flow during menstruation since 7 to 8 months. Also, she has chief complaints of pain during menstruation since 7 to 8 months. History of present illness. Patient presented with the chief complaint of heavy flow during menstruation with history of bleeding for 9 to 10 days per cycle. The cycle duration was about 18 to 20 days with soakage of 8 to 9 pads per day. Associated with history of passage of clots. It is also associated with pain during menstruation, which is dull aching in nature and starts on the first day of menstrual cycle, maximum on the first day, and usually subsides with the end of menstruation. There is no history of intermenstrual bleeding, postcoital bleeding, PV discharge, dyspareunia. There is no history of fever, generalized weakness, or fatigue. There is no history of bowel or bladder disturbances. There is no history of bleeding gums or epistaxis or bleeding in the rectum. Menstrual history. Patient attended menarche at the age of 14 years. Her previous cycles were regular, 28 days duration, bleeding for 4 to 5 days, and used 2 to 3 pads per day. There is no history of soakage of clots and dysmenorrhea. But her current cycles were 15 to 20 days duration. She used to bleed for 9 to 10 days and with soakage of 8 to 9 pads per day and associated with history of passage of clots and dysmenorrhea. Her LMP was 8 May 2023. Obstetric history. Her duration of marriage was 15 years. She got married at the age of 26 years. She has 2 childs prior to living to all previous to normal full-term deliveries, and last child was 10 years ago. Both are institutional deliveries and both child are alive and well. Patient didn't use any contraception between 2 pregnancies. TL done 8 years back. Past history. Patient is not a known case of diabetes, hypertension, sickle cell anemia, thalassemia, thyroid disorders, or bleeding disorders. There is no history of blood transfusion or other abdominal surgeries. Treatment history. Patient gives history of intake of some medications during menses for 4 to 5 days for menorrhagia complaint from private hospitals for the presenting complaints, but the complaints were not relieved. Personal history. She has normal bowel and bladder habits, sleep and appetite habits. Habit is also normal and addictions are nil. Family history is not significant. On
Okay.
general exam,
Just a minute.
Yes,
Okay.
ma'am.
If you will go to the examination, let's first
cannot.
clarify the history. Okay.
Okay, ma'am.
If we just go to the demographic histories,
Yes,
I
ma'am.
think you have covered everything in the demography which would affect the patient's management. You have told us the age,
Yes, ma'am.
isn't it?
Yes, ma'am.
And you have told us the marriage history.
Yes, ma'am.
Anything else in the demography which we should be asking for completion purpose also, as you are a postgraduate, and for management purposes also, you know. So what else does the demography contain which
Ma'am.
will affect?
Yes, ma'am. In demographic, we can ask what is the occupation of the patient, occupation of the husband, and her socioeconomic strata, ma'am.
So does that affect the management or not?
Yes, ma'am. It will affect the management. Ma'am, if she belongs to lower socioeconomic strata, then we have to manage the case accordingly. She cannot go with the higher, ma'am.
So many things are there, no?
Yes, ma'am.
Where she resides, how many
Yes,
times
ma'am.
can she follow up to us?
Yes, ma'am.
What's
For
the
follow-up
restriction
also.
there? What is her education? Will she understand what we are explaining to her? What type of
Yes.
counseling we should be having, you know? So all these things are taught to you as a postgraduate since an undergraduate times, and it
Okay.
has some or the other bearing. Okay, so we
Yes.
should never miss just the
Okay, ma'am.
age and marriage. That doesn't, give us any clue of what kind of patient you are going, it is in front of you, isn't it? So is
Yes.
it a rural patient? Is it a well-educated patient? Will she understand what is it telling you? What is her education? What is her occupation? Is she a professional? Is she a laborer? What type of work she is doing, or she is a housewife? So each and everything is relevant, and you should never have such kind of incomplete history in front of you. So remember that you have to be now your chief complaints.
Yes,
Heavy
ma'am.
flow during menstruation and pain during menstruation. Go to the next slide. Madam, you also can.
Yes, I will come in during menstrual history. And then after completion of the history, I have some comments to make. Till
Yeah.
the time, we can continue.
So go to the next slide. History
Yes,
of
ma'am.
present illness. Okay. History of bleeding for 9 to 10 days per cycle with soakage of 9 to 8 to 9 pads per day. Okay.
Yes.
So again, this is a very it's kind of history where patient should not be waiting for 7 to 8 months at all, with 8 to 9 pads per day, and associated with pain during menses, no intermenstrual bleeding, postcoital bleeding. But what about fever? Fever, why have you asked in this patient? Is it relevant?
Ma'am, to rule out, ma'am, PID, pelvic inflammatory disease, if she's having
Yeah,
an
but
infection.
how many times it leads to fever really? Because it will not be acute PID, isn't it?
Yes, ma'am.
Because it is since 8 to 9 months. But then, is it not contradictory that she's not having generalized weakness and fatigue? I know that you are expecting anemia and you are targeting the symptom towards anemia. But as Madam has said, she's bleeding since 8 to 9 months and 8 to 9 pads per day. Passage of the clots.
Yes, ma'am.
It's a bit
Yeah.
contradictory. You should be ready with the explanation there.
So it is surprising that she is bleeding in 8 to 9 pads per day. And she's also having clots. And she's hardly having again 8 to 9 days period which is bleeding free. So hardly any days and she's again having menses, and it is very, very unusual that she doesn't have any weakness, she doesn't have any fatigue, she has no other complaints. Okay, so you have to be, when you take the history, it has to be in depth. Okay, and so here, and fever history is not at all relevant here in this case, because specifically if patient is having heavy menstrual bleeding, she's passing clots. So here the fever is, because in a case of PID, you're not going to have such huge bleeding. First of all, the main complaint would be dysmenorrhea and a congestive type of dysmenorrhea in patient of PID, and other symptoms, maybe urinary symptoms would be more common, and inflammatory markers, those kind of symptoms would be more common. But so that's why I am talking in this way, because then what happens, your examiner will concentrate on these few things, and that's very important. It's always like you lead the examiner.
Yes.
So if you are, it's you lead. So now you leading me towards fever, which is not correct. Now why you have asked bleeding gums, epistaxis, bleeding per rectum?
Ma'am, to rule out any bleeding disorders, ma'am.
Okay,
Then
so
will
why
she stop bleeding then? If she's having any bleeding disorder,
Yes,
is
ma'am.
it likely that she will bleed only during menstruation?
No,
Yeah.
ma'am.
So, and of course, she will tell you upfront, if she's having bleeding gums, isn't it?
Bleeding.
Epistaxis, and the bleeding gums and epistaxis will not, is it like acute condition she may be having for a longer duration of time? That may be a presenting complaints, isn't it? So, all these things is sort of irrelevant when you're asking as a negative history. Okay. So pain during menses is one. So otherwise also, does she have pain apart from pain during menses?
No, ma'am. She has pain only during the menses.
Only during menses, and otherwise she does not have pain. It subsides
With
after
the
the end of menstruation. Okay. Let's go to the next part.
So when you're talking about menstrual history, usually we don't know when you have taken the history, right?
Okay,
And you
ma'am.
are saying that LMP is 8.5,
8-5.
isn't it? And one of the goal of treatment is she may be presenting to you with heavy bleeding, isn't it? During the bleeding only she must have come. So
Yes,
we don't know how many days back you are examined. So it is always better when you are presenting a case that LMP, because here you are not going to calculate EDD, right? So date doesn't matter. What matters is how many days back. So it will help you in investigation also, because we will like to do, if at all you want to do USG, the premenstrual USG will give you the indication whether the endometrial hyperplasia is there or not, isn't it? So it is better that you may say that LMB is so many days back, on which day you are taken or you
I
are
hope
taken
you are
the.
understanding what
Yes,
ma'am
ma'am.
is saying.
Yes,
So you
ma'am.
said she is having menorrhagia since 7 months, but presently is she bleeding, or her menses was 8 days back and it has stopped now? Okay, so you will know when to start, if you're starting progesterone, or if she is in a bleeding phase, what to do. So all that is important. If we are talking of the month of May, then we don't know what is happening now in August. So presently you should have said that, okay, she bled 8 days back, now there is no bleeding, or she's continuously bleeding even now. So that will give us an idea what kind of acute management she needs.
Yes, ma'am.
Okay, so that is what ma'am is trying to tell you. So the LMP in 8th of May, what happened till August?
Ma'am, actually, I have taken history in the May, so that I have mentioned that the 8-5, ma'am.
So then you should have talked about what happened later. What did you give? What? So you haven't told us anything that she was admitted. Then we did this, we did that.
No, I think she's presenting a case as if she has taken now. So okay, we will accept that. But if you say you're taken it in month of May, then how many days back she had her LMP, and when you examined her, whether she was bleeding or not. How many days back she was having menses.
So you should have said, I examined in month of May, but at that time she was bleeding. Was she acutely
Yes.
bleeding when she came to you?
No, ma'am. Actually, she just completed her menses, ma'am. Not in bleeding phase.
Okay. So your goal of management changes, no?
Yes, ma'am.
So that's why it is important to say how many days back and is she bleeding at present. Okay.
Okay.
Next slide.
Next.
Obstetric history.
Okay. Go to further slide. Next slide.
Yeah.
Okay. Next slide.
Now here again, this is again suspicious, isn't it? So she gives a history of intake of some medication during menses for 4 to 5 days for menorrhagia. So she is bleeding from 7 to 8 months.
Yes, ma'am.
She has taken treatment only for 4 to 5 days. Is this what you are suggesting?
Ma'am, actually, she was taking repeatedly some medication from private hospital when she used to bleed during menses for 7 to 8 days. To relieve the bleeding, she was prescribed some maybe antifibrinolytic or NSAIDs to relieve the complaints, but her complaints were not relieved after that medications, ma'am.
See,
I
there are two ways.
suggest, yes, ma'am, please go ahead.
There are two ways of not relieved. That is, when she is on treatment, still she is not relieved, or
Yes,
when she took the treatment, she was relieved, but in next cycle again there was a recurrence. So there is difference in two, right?
yes, ma'am.
So what was the case here? Whether during
Ma'am, for
treatment,
that period of time, complaints were relieved, but from next cycle, she was having the same complaints, ma'am.
so when she was on treatment, she had relief.
Yes,
Again,
ma'am.
this okay, her age is 41. What happens usually, you know the diagnosis beforehand, and then you are focused that okay, you know the age and everything, but you should keep an open mind, right? Don't go with
Yeah.
the diagnosis first. Then you may be misled in taking a treatment history or anything, isn't it? So suppose you have planned for operative and she says that no, I want to do it after 3 months or 4 months, then this history is not useful, isn't
Yes,
it? If you take a history like that she was relieved when she was on medication, but there was a recurrence, then you may again try it for a few months, isn't it?
So what I suggest that the treatment history has to be detailed. Okay.
Yeah.
When she went, what did you examine her case sheets? What all was done? Was her investigation done? It is really surprising that for 7 to 8 months, no investigation has been done. So was an ultrasound done? What did you find? What type of treatment did she take? So if you are saying 4 to 5 days, you're suggesting it is a non-hormonal treatment. Okay. Did she not receive anything for treatment of anemia at all? That is also surprising. So you need to really investigate in detail what she has received. Is it that her complete medical management was done and it is a failure? Then you have to go for surgical management, isn't it? Or maybe she has not taken adequate medical management, or she has not understood how to take the medical management. Many a times what patient does, they take progesterone for 4 to 5 days.
Yes.
And then the
Yes.
bleeding stop. They think, okay, it's done. And then they stop. And again, the bleeding start because they have stopped progesterone. So you really need to go in depth of the treatment history, where this has been missed here. And so
And
that
most of the
come to
times,
know. Yes, ma'am.
and most of the times, I suggest that before you go to treatment history, it is always better to form a provisional diagnosis in your mind. Because once you go to case sheets, see the ultrasound and all these things, then you become biased. So before go to treatment history, when you're talking with the patient, only with history itself, try to form a provisional diagnosis with differential diagnosis in your mind, so that it
So now,
guides
what is
you.
your provisional diagnosis and differential diagnosis from history?
Ma'am, since it's a 41-year-old female para-2 living with chief complaint of heavy flow during menstruation and pain during
No,
menstruation.
so this is
No,
your,
no.
this is not a diagnosis.
Okay,
Yeah.
ma'am.
Diagnosis
some
should be very
diagnosis.
precise. And every word in the diagnosis should affect either your management or treatment. Right?
मयूरी मैम ने इतना प्रिपेयर किया उसके लिए.
Abnormal uterine bleeding, ma'am. My provisional
But
diagnosis.
is it enough? Is it enough diagnosis?
Menorrhagia,
See,
ma'am.
abnormal uterine bleeding, if it
Yes,
is in a
ma'am.
18-year-old girl, in 25 years old lady who is
Yes.
willing for fertility, so age of the patient is must,
Yes,
her
ma'am.
parity is must, isn't it?
1-year-old para-2 living to ma'am with menorrhagia. Most likely, my provisional diagnosis is ma'am abnormal uterine bleeding, ma'am.
Yeah, but abnormal uterine bleeding,
Yes,
there
ma'am.
are so many reasons.
PD
So from history, what are you suspecting? She's a multipara with dysmenorrhea. You have not yet examined her. She's
Yes.
not having intermenstrual bleeding. She's not having excruciating pain. There is no history of infertility, isn't it?
Yes, ma'am.
So,
So what are the
for
what are the differentials for menorrhagia? Such kind of bleeding.
for AUB,
Ma'am, uterine fibroid, ma'am,
Okay.
adenomyosis, ma'am.
so which one will you pick first?
Ma'am, first, ma'am, I will suspect ma'am uterine fibroid.
Why?
Why not adenomyosis?
Why not
Ma'am, in
adenomyosis?
adenomyosis, there is also ma'am dyspareunia, ma'am.
No, not
not
always.
necessarily.
Not
No.
all.
Not always. She has dysmenorrhea. She has menorrhagia. It could be adenomyosis. So,
Yeah,
okay,
then
let us
multiple.
give you a message that you
Ma'am.
have to keep open mind. Okay?
Yeah.
It could be adenomyosis. It could be dysfunctional. It could be this. It could be fibroid. Okay, fine. And then you go and investigate one by one. Fine.
Ma'am,
Let us go into the examination, ma'am, so that we can ask some questions on
Yeah.
fibroid as well.
Yeah.
If you understand, you go to the examination quickly. In 2 minutes, you give us a with general examination first.
Ma'am, patient oriented to time, place, and person. Is
Positive findings.
okay, ma'am. Ma'am, her pallor was present, pulse was 108, and breast examination and thyroid examination were normal. Ma'am, then positive findings on
Go for next.
yes, ma'am. On per abdomen examination, ma'am, on there is central mass of around 20 weeks gravid uterus size present in hypogastrum and umbilical region. It is firm in consistency, non-tender with regular margins, freely mobile from side to side. Lower margin of the mass not felt. On percussion, there is dull note heard over the mass. On auscultation, there is no bruit heard over the mass and bowel sounds were heard. On per speculum examination, cervix was central. It appears healthy and cervix was pulled up. There is no evidence of growth, no discharge or no active bleeding noted. Ma'am, on vaginal examination, it appears pale and vaginal mucosa healthy. On per vaginum examination, same mass felt in the PV. On uterus, it is firm in consistency with regular margins and freely mobile from side to side. Uterus not felt separately, then movements are transmitted to the cervix and bilateral fornices were free and non-tender. On per rectal examination, there is bilateral rectal mucosa free and no nodularity noted. So my provisional diagnosis, ma'am, 41-year-old female, probably case of uterine fibroid with menorrhagia.
There are many problems in the examination. If I really go with it, then starting from the general examination. Your patient is having tachycardia. Her GC is moderate. So and tachycardia is there. SQ2 you have talked about. So TPR, BP first of all. Remember the vitals. Okay. Then of course breast examination, thyroid is fine. Respiratory system and CVS is fine. Per abdomen. Next. BMI also you have to tell,
Yeah,
very
you have
important.
to tell BMI, which is
Yeah,
very important.
BMI
in
of the
this
patient
case.
is very important. What is the weight? What's the height? What's the BMI? That will affect your management. Okay. It will always also tell us if she is having any other high risk factor for hyperplasia or uterine endometrial carcinoma, because that also comes in the differential diagnosis.
Yes.
Why we are before the examination, that also comes in the differential diagnosis. Keep a wide vision.
Corpus cancer.
Okay, per abdomen. Central mass of 20-week size present in the hypogastrium. Only hypogastrium, if it is 20-week size, it is coming up to what level? Is it not only in the hypogastrium? How many, how do you divide the abdomen? So I'm just telling you things you should remember. Okay.
It is
Then-
better not to mention because everybody knows when it is 20 weeks.
So
It
when
is
it is
better to
20 weeks,
avoid
it is coming up to the umbilicus. It is not only in the hypogastrium, isn't it? It is firm in consistency, non-tender. Is it only one mass? You are saying regular margins. Regular margins mean, are you suggesting that it could also be an ovarian mass? So if you are talking of fibroid, so you cannot say regular margins.
Irregular
Really
Maybe it is-
mobile from side to side. Again, madam, that is also, you know, when it is a 20-week size fibroid, mobility will be restricted. Isn't it? Lower margins of the mass is not felt. That is fine. Okay. And then dull note on percussion, auscultation, no blue bowel sign. Next slide, please.
This regular margins, I think she means that it may be an intramural fibroid. That's why. That is, she's ruling out the subserosal fibroid, isn't it?
So again, the cervix cannot be central if it is pulled up. Where it is pulled
Yeah.
up, it is
Is it not
behind the
contradictory?
symphysis pubis probably. Is it? No growth, no discharge. Madam, you can take over here for speculum and per vaginum.
No, per vaginum, I feel go to per vaginum exam.
Yeah. Per vaginum.
I'm same slide.
Next slide. Show us the next slide. Yes.
So here what I feel is, do you move the mass and then feel the cervical movements, or you move the cervix and feel the movements to the mass? Exactly what you do.
So again, here it is not very clear whether it is uterus which is enlarged, like you said, uterus not felt separately. So are you feeling the uterus or are you feeling the mass? That you have to tell us, or it is the uterus which is enlarged to 20-week size and there is no separate mass. Okay, so that is what madam is asking. You move the cervix and the mass moves it with it, or you do not move the mass and cervix moves it. Isn't
So
it?
movements are transmitted to the cervix. नहीं होता है. Usually it is opposite way around.
Cervical movements are transmitted to the
Transmitted to
mass.
the mass.
Okay, and why is it not an ovarian mass if it is 20 weeks? From your findings?
Ma'am, there if this is the ovarian mass, ma'am, the mass will be felt, ma'am, separately from the uterus. On per abdomen, there will be groove, ma'am, between the ovarian mass and the this uterus, and this also this mobility, ma'am, this cervix, it movements are not that I have written wrong, ma'am. This sign will
Okay.
be
In even the per rectal examination, you have said bilateral rectal mucosa. Is it bilateral rectal mucosa?
No, ma'am. Sorry, rectal mucosa free, ma'am. Bilateral.
Why do you want to say that the rectal mucosa is free? You want to suggest that it is going to spread to the rectal mucosa? Are you considering it as a malignancy?
Ma'am, to rule out, ma'am, malignancy, it is a malignancy or in case
20-week size, mass, freely mobile. Are you suspecting malignancy when the cervix is healthy? So these
I
are
think
the
she is completing the list. She is completing the list of examination.
But see,
Wondering-
even if you, then no nodularity present, she has said. That
So you
means,
can just say that per abdominal, per rectal examination revealed no abnormality.
yes.
When
So
you are
how you
suspecting,
go about, yes, ma'am, please go ahead.
as madam is saying, if you are suspecting malignancy, then go step by step about for the parametrium, about the rectal mucosa, about the nodularity. But here you want to complete the list, isn't it? That per rectal examination is to be done in every gynae case. That's why you are suggested. But then you can cut it short to per
Okay, ma'am.
abdominal examination reveal no abnormality.
How do you proceed in this case?
Come to the diagnosis first.
Yes,
Can
ma'am.
we just discuss on the framing the diagnosis? What have you missed over
Yes.
here from management point of view?
Ma'am, parity. Parity.
It is very important. And one more thing, from management point of view, have you missed anything else?
I mean,
Anemia,
yes, ma'am.
isn't it?
Yes.
Patient
So,
is having tachycardia, patient is pale, urgency is moderate. All these three things are suggesting that she is in bleeding phase actually. Or she has bled a lot and she has come to you. So again, acute management would be different in this case as compared to a chronic case, isn't it?
so your diagnosis should be complete, which will give you the complete information. And it should not have unnecessary things, right?
Okay, ma'am.
Okay. As madam has asked, how will you proceed now? Is there any need for confirmation of the diagnosis or your clinical diagnosis is enough?
No, ma'am, we have to confirm the diagnosis, ma'am, by investigations, ma'am.
Which investigation will confirm the diagnosis?
Ma'am, transabdominal ultrasound, ma'am, will confirm the diagnosis.
Okay, but on this ultrasound, what else will you ask for? When you are writing a requisition to your radiologist friend, what
Yes,
all you
ma'am.
will like to know?
Endo, ma'am, I will also ask to comment on endometrial thickness, ma'am.
So here comes the importance of LNP. How many days back,
LNP.
isn't it? So if she's
Yes,
not
ma'am.
having bleeding at present, then
Yes,
you will
ma'am.
like to do it in premenstrual phase or on the first day of the cycle, isn't it?
On the first.
Why? Why you want to know ET, endometrial thickness?
Ma'am, to rule out endometrial hyperplasia, ma'am, risk of endometrial cancer.
Okay.
Ma'am.
Hmm. So now you have confirmed that it is fibroid. But is it
Fibroid, ma'am.
enough just to say that it is a fibroid?
Means, ma'am, on transabdominal ultrasound, it will show, ma'am, confirmed diagnosis.
How?
Yeah, but
What is the features?
Ma'am, we will see a well-defined hypoechoic lesion, ma'am, on the ultrasound, ma'am.
only one lesion? Are you sure?
Yes, sir. No, ma'am.
So that is what I'm asking.
Depending.
But yeah,
So
so
if
what
it
will
is a
you
single
suggest to the
fibroid, you will have to map the fibroids. How many in
Yes,
number?
ma'am. MRI for we can do, ma'am, MRI for the mapping of the fibroid, ma'am.
Only somebody is speaking in between. Okay. What else how would MRI help? Otherwise also. What additional information would
Ma'am,
tell
to
us?
differentiate between adenomyosis and ma'am, uterine fibroid adenomyosis.
So already the ultrasound has shown you such a huge mass, hypoechoic. You are again suspecting adenomyosis also.
No, ma'am. In MRI, even fibroids less than 5 mm can be diagnosed, ma'am. So if we are planning to do, ma'am, myomectomy in infertile patients, so MRI will be, ma'am, better to
In this
localize all.
patient, in this
No, ma'am,
present
not
patient.
in this patient, ma'am. In general, I'm telling.
So let us stick to this patient if we want. If you are talking of MRI. So what kind of treatment are you planning for this patient? Medical or surgical?
Ma'am, surgical treatment.
Why?
Ma'am, since she is 41-year-old, para to living to, family is completed, ma'am, and she is having heavy menstrual bleeding with anemia, and the uterus size is, ma'am, so big that is approximately 20 weeks rabbit uterus size. And if she is willing for surgical treatment, I will go for, ma'am, for surgical treatment only.
What options are there?
Ma'am, in this case, since it is approximately 20 weeks gravid uterus size, then ma'am, for this case, total abdominal hysterectomy will be a good option. Otherwise, if the size is less, there are ma'am more options. If less than 14 week size, we can do ma'am vaginal hysterectomy. 14 to 16 week size, we can do total laparoscopic assisted hysterectomy.
Mode of hysterectomy is the next question.
Okay,
First
ma'am,
of all,
hysterectomy.
What are the options available to this patient? So if the, see, 20 week size you are given, she doesn't want to get operated, then what are the options?
Ma'am, to relieve the symptoms, we can do ma'am, ma'am, she doesn't want ma'am surgical
Oh.
treatment. She doesn't want TH.
She doesn't want surgical treatment, is it? So tell us the medical options.
Okay, ma'am. To reduce, firstly, we will for anemia purpose, we will check the hemoglobin and we will give iron supplements, etc. Of iron tablets and folic acid tablets to build our hemoglobin. Then to stop the bleeding, antifibrinolytics just such as tranexamic acid, we will prescribe
So
maximum.
when you are giving any kind of answer, you need to classify, isn't it?
Okay, ma'am. Non-hormonal
classify.
treatment and hormonal treatment, ma'am.
Yes.
First to treat anemia, we will give iron supplements, folic acid. Then we will start from non-hormonal treatment. First,
can I intervene?
yes,
See, she is having menorrhagia and symptomatic anemia. How many months she will require if she is not going for operative treatment? How many months she will require to build up the anemia with oral treatment?
no, ma'am. We will check the hemoglobin if she's she's having a severe anemia. We will transfuse the blood if she's not hemodynamically stable. HB is less than 7, or we will give injection iron sucrose, ma'am, 200 mg. Because oral will not be
Only 200, or you will
no, ma'am,
calculate
for
the
5
dosage?
we will calculate the ma'am for according to 5 injections, ma'am. Alternate days we can prescribe
5 injections. So you need to calculate the
yes,
deficit,
ma'am, we will calculate
and accordingly you will
deficit.
decide.
Accordingly we will decide, ma'am.
Okay, that is one part. So her
Yes, ma'am.
general condition first have to be looked after. Then
ma'am.
you're going to go for specific management. For that, of course, you'll have to investigate the patient. You're done the ultrasound. You want to do the MRI. If you're going to go for surgical management, you will like to know the mapping. You like to know where the ureters are. Are they getting entrapped? How you will plan, what route you want to plan, all that. And to give options to the patient, you have to thoroughly investigate the patient. Then, of course, hormonal and non-hormonal. So initial management. So hormonal, you will have to, whether you will get first non-hormonal or hormonal, that you will decide. And of course, that's why I'm asking you, what are the treatment modalities?
Yes, ma'am. Ma'am, in non-hormonal treatment, we will start with
That we have
non-steroidal.
you have already talked about non-hormonal.
NSAIDs. Okay, ma'am. On hormonal treatment, ma'am, progestogens are given. Norethistron acetate, it is given at the dose of 5 to 10 mg thrice a day from day 5 to 25 day of the menstrual cycle for 3 to 6 months. Or we can give ma'am a medroxy progesterone acetate tablet 5 to 10
Is it going to help to reduce the size of the fibroid?
No, ma'am.
Or just to take control the bleeding if it is ongoing?
Ma'am, to control the bleeding, ma'am.
So any modality to reduce the size of fibroid?
Ma'am.
Is there any modality which will reduce the size of fibroid?
Ma'am, in medical treatment, GnRH analogs can be given, ma'am, or selective estrogen receptor modulators, or meloxifene or gestated.
So as a postgraduate, you should be knowing how effective it is, what is the efficacy, how many duration you're going to start, how much time it will take to reduce the fibroid, on whether you're going to give it prior to surgery. Okay,
Yes,
if you said you would like to do a myomectomy if she's a infertile case. So
yes,
which patient what to use, for how much duration, and what is the efficacy, so that you can counsel the patient accordingly, and she will also know what to expect if this kind of management is started. And of course, then you can, is there any conservative surgery we can do for this patient? For this patient, hardly any, isn't it?
Ma'am, you
Why
can
she's
If it is a smaller fibroid, or it is a fibroid which is submucous in variety, then what other options?
Ma'am, if submucosal variety, ma'am, we can do, ma'am, hysteroscopic myomectomy, ma'am.
How many setting will you take for this hysteroscopic myomectomy? How many
Ma'am,
settings you will do this myomectomy? Corona remedies, please mute yourself.
for hysteroscopic myomectomy, ma'am, 2 settings. Small fibroid, submucosal fibroid is there.
It will depend
Upon the size of the size of the, ma'am, myoma, it will depend.
and
And number of the myomas.
and FIGO classification.
Yes, ma'am, type 0 and type 1, we can do submucosal.
Is there a classification? You should
Yes, ma'am.
classify, isn't it?
Type 0 and type 1, ma'am. We can do, ma'am, hysteroscopic myomectomy.
May I know why she's not ready for surgery? According to you, what is the best treatment for her?
Ma'am, surgery, ma'am. Abdominal hysterectomy will be good.
Best
for her.
treatment. Then why she's not ready? What are her concerns?
Ma'am, premature ovarian failure, ma'am.
Are you going to remove her ovaries? She is 41-year-old.
No, ma'am. While doing hysterectomy, also when we clamp, ma'am, uterine vessels, arteries, also there is a chance that, ma'am, blood supply to the ovarian vessels may.
How much % chances are there that this patient will go in premature ovarian failure?
Exactly, I do.
So you have to, as a postgraduate, all these concerns also.
And again,
You are going to preserve our ovaries or not?
Preserve, ma'am.
So you are sure that you are going to preserve the ovaries, or you will examine when you open and then decide?
it is a hyperestrogenic state, isn't it?
You have decided, or you're going to examine and then you will take the decision?
Ma'am, I will examine.
And how much are you going to try and counsel her, or you will accept her decision of not to get operated?
I will counsel her, ma'am.
But are you going to operate her immediately? What
No,
is a
ma'am.
way to counsel her? What is a way to counsel her in this case?
First, I will make, ma'am, fit her for surgery. I will build up her hemoglobin.
Yeah, you are going to do that. So can you tell her that, yes, I honor your decision of not getting operated. Let us see with this medical management, how much improvement is there. And if no improvement, then we will again discuss, isn't it? So
Is there
that
any role of DNC in this patient prior to going for radical surgery? That is hysterectomy.
DNC, ma'am, for this patient, ma'am, since it is big size, we can't do.
You can't do.
Matlab, ma'am, there is no rule,
If
ma'am.
it is a hyperplastic endometrium, would you not like to take a sample of the endometrium and find out?
Yes, ma'am. With the help of, ma'am, People's aspirator, we can do, ma'am, or Carmen's cannula.
Patient of HMT, patient of abnormal uterine bleeding, would you not like to know the pattern of the endometrium? So you have to evaluate the patient correctly to rule out endometrial hyperplasia as well as endometrial carcinoma, unless that it is a very thin endometrium and she bleeding phase. Okay, so again, your decision has to be depending on what kind of bleeding phase she is coming to you. If the huge fibroid is there, That is the prime diagnosis, but there could be associated abnormalities as well. So we should not miss those. So that is my concern for your patient. And of course, route of hysterectomy and all that can be planned once you have considered whether you're going for medical management or she needs a surgical management. Madam, from your side, comments.
Yeah, what do you think that response of medical management will be there? Do you think that the fibroid will disappear?
No, ma'am.
Isn't it? So you yourself also know that what is the success of medical management in this case, isn't it? So the role of medical management may be for the time being, till the time you correct her anemia, till the time she prepares herself for a surgical management and all. But
Uterine
otherwise,
embolization. What is your opinion about it in this case?
Ma'am, in this case, uterine embolization is not of much use because it is used in medium-sized fibroids in multiparous women.
I don't agree with that.
see, active control of bleeding can be obtained with uterine artery embolization, isn't it? And what can be the operative difficulties you may encounter?
Ma'am, as this is such a big fibroid, maybe there will be distortion of the anatomical, normal anatomy of the patient.
In
There-
which fibroids there is distortion of normal anatomy? If it is fundal, will it be any distortion?
No, ma'am, subserosal.
See, the site of fibroid also matters. If it is in the body or cervix. So commonest is cervical fibroid, isn't it?
Cervical fibroid. Okay, ma'am. Ma'am, there will be risk of damaging to ureters, ma'am.
So what precaution you will take to avoid the damage to the ureter?
Ma'am, digest stenting can be done, ma'am.
So first of all, preoperatively, you will try to find out where the ureters are, either you and MRI.
Most of the ureters
You will
and
have to do some urological studies,
yes, ma'am.
isn't it? Imaging.
Urography, yes. Ma'am, before starting the operation, we can do digest stenting and also during operation, ma'am, skeletonization of the uterine arteries should be done, ma'am.
So basically, we would like to identify where the
Identify
ureters
the ureters
are,
are,
that you
ma'am.
can protect them, isn't it?
Yes, ma'am.
Any other complications can occur during surgery?
Ma'am, hemorrhage can occur, ma'am.
So what is your precautions for that?
Ma'am, preoperatively, blood should be arranged.
How will you reduce bleeding?
Ma'am,
Because you are operating on one side, and when you start operating from second side,
yes,
so
ma'am.
the backward bleeding can also occur, no?
Yes.
How will you reduce that? How will you reduce the bleeding? Or if you are expecting bleeding, can there be help of a medical management?
Yes, ma'am. Antifibrinolytics intraoperatory should be transfused, ma'am. Also, there can be, ma'am, intraoperatively bowel bladder injury can happen, ma'am.
Unless you are a very sloppy surgeon, that possibility. Okay. So because it's a huge fibroid, many a times it is more easy actually. If it's a 20-week fibroid, the planes are very clear. And unless she is a previous cesarean section or something, this patient having vaginal deliveries. Okay.
And ma'am, to decrease the bleeding, ma'am, 20 units in 200 ml of vasopressin is, ma'am, injected into the, ma'am, myometrial surface to make the, ma'am, myoma less vascular. So during surgery, plane can be find out, ma'am, there will be less bleeding.
Okay, which incision will you like to have? What is the abdomen?
In this case, ma'am, as it is a 20 weeks, I will prefer my midline vertical incision, ma'am.
Is it? I will just ask you a question. That you have done a cesarean section through financial incision. isn't it? And you want to extradite the uterus for some reason, for PPH or
Okay.
anything. Can you take out the 20 weeks uterus just delivered? Isn't it?
Yes, ma'am. It will depends on the surgeon expertise.
Okay. So it's not always. You may require, you may say,
Yes,
isn't
ma'am.
it? Okay. I think we are running out
Yeah,
of the time for this case.
yeah.
Any
Thank you
comments
very
from
much.
Garima? Thank you, thank you.
Ma'am.
And
Sushma,
very
thank
nice
you.
presentation, Mayuri.
Sushma, Dr.
Yeah.
Pragati, Prachi.
Yeah, it was wonderful. Two examiners really very so affectionate and motherly, teaching so nicely to her. Very nice.
Yeah, thank you. Thank you, Bhakti,
Thank you.
also for calling number of times. And
Ma'am, I am extremely thankful to Taide ma'am and Swati ma'am for giving us the time and valuable suggestions for improvement and guiding us so nicely. Thanks for being gentle to us, ma'am. Thank you so much.
thank you so much.
Can
Thank
you please
for-
wait 1 minute? Corona people, can you take a snap?
Yeah.
Can you just
First, we need to remove the slide share.
slides, please? Slides. Yes, Mayuri.
Yes, ma'am.
Ma'am, I would like to thank all of you.
Dr. Divya is there.
Stop share, please.
You really taking her
Stop
graduate
sharing.
towards
Mayuri.
Yes, ma'am. I've stopped sharing.
Hello, good evening, Dr. Divya.
hello.
Good evening.
Hello. We
Thank
can
you.
just have a one photograph because the examiners may go again. That's why.
Yeah.
Am I audible?
Thank you.
This what?
Done.
Thank
It is
you.
done.
Thank you very much.
You can be also there for the next this thing discussion.
I'm having a
If
panel
possible, yeah.
discussion again
May I
on
can
EPD.
understand.
Yeah, thank you.
That's why we took the photograph.
Thank you.
Yes,
Thank you so much,
Thank you, Sushma.
Sushma.
I welcome our chairpersons for the session. Dr. Rajshri Patil ma'am, professor in HOD, OBGY department, GMC Gondia. Ma'am is MBBS MD, April 1992. Ma'am has attended various national and international conferences. Attended various CMEs and workshops. She has published 7 international and 1 national publication. She is peer reviewer for OBGY journal. She participated for study on international survey on practice variations in management of third stage of labor for Global Network of Perinatal and Reproductive Health 2002 in Bulletin of WHO. Ma'am has participated in many workshops, IVF, ET. She has attended the refresher course, medical education technology, good clinical practices and biomedical research workshops, regulatory updates in clinical trials, and organized personality and skill development, stress release, and meditation workshops for undergraduate students and faculties in 2009, 12, 19, and 2020. Welcome, ma'am. I also welcome Dr. Alhad Mohite, sir. He is fetal medicine consultant, co-founder NFMC, done his MBBS and MD in radio diagnosis from GMC Nagpur, worked as a senior resident at Nizam Institute of Medical Sciences, Hyderabad, worked as chief radiologist at Mandi, Himachal Pradesh, and visited Thomas Jefferson University Hospital, Philadelphia, USA, and was trained in fetal imaging, CVS, amniocentesis, cord blood sampling, and fetal reductions, and conferred with fellowship in maternal fetal medicine. And he's actively practicing in fetal medicine in Nagpur since 2015. Welcome you, sir.
Welcome, Dr. Alhad. Nice to see you.
Thank you. Same here. Thank you.
Yeah,
Am I
you can
audible?
start. Yeah.
Yes. So,
Can you put the slide of the
yes.
speaker,
Yeah.
Mayuri?
Yes, ma'am.
The previous slide. Yeah.
Yes, ma'am.
Yeah. So I am also very much eager. This is first time I am meeting Dr. Divya Singh, who is MD and DNB MNAMS. She has done her MBBS from IGMC Shimla. She's a gold medalist, and did her MD radio diagnosis, that too with a medal from PGI MER Chandigarh. She is fellow in advanced OBGYN ultrasound Mediscan Chennai, and she had short-term training in medical genetics, ICMR, NIR, RCH, Mumbai. Currently, she is working as a consultant radiologist, prime imaging and prenatal diagnostics, Chandigarh. She is ultrasound trainer and basic training content reviewer of ESOG UK. She is also member of ESOG CME task force. She has received many awards awarded by the Ministry of Health, Government of India, for providing exemplary service to pregnant women in Chandigarh 2018. Best oral paper on ultrasound in endometriosis in Sonocon 2020. She has many publications and conference papers to her credits, and she has contributed in books also, contributed 2 chapters in books. So we welcome you, ma'am, Dr. Divya Singh, and the next time is yours. Welcome.
Thank you, sir. Good evening, everyone. I would like to thank Dr. Mohite for the kind introduction and express my thanks to Dr. Sushma and Dr. Pragati for having me thought worthy of this forum. In the next 30 minutes or so, I will speak on certain, if I may be allowed to share the screen, sir. I cannot.
Mayuri, please stop sharing.
Thank you. I hope you can see my screen now, ma'am.
Yes, yes.
Yes, thank you. So in the next 30 minutes or so, I'll be speaking on the diagnosis of endomyometrial pathology by ultrasound in abnormal uterine bleeding. And I think to this audience, I need not tell the definition, but just for the sake of the flow of presentation, abnormal uterine bleeding is any disturbance in the menstrual cycle which involves frequency, regularity, duration, and volume of flow in the absence of pregnancy. According to the revised terminology by FIGO, there have been certain changes in terms of the various parameters that are to be assessed when we are taking history of a patient with abnormal uterine bleeding, and I'm sure you're all aware of them. The etiology of abnormal uterine bleeding, we have been learning this since time immemorial. It's remembered by the mnemonic palm coin. And it is the palm part which I would be covering today, which includes endometrial polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. Because these are discrete structural entities which can be evaluated visually using a combination of imaging techniques like ultrasound and histopathology. Please remember, whenever you are evaluating a patient with abnormal uterine bleeding, transvaginal sonography is indispensable. So one can get a general overview of the pelvis by doing a transabdominal sonography first, but transvaginal sonography is indispensable. That has to be resorted to. And if there is a large mass, say for instance, a large fibroid, as was discussed in the case previously, it also becomes important to evaluate the kidneys and the ureter for back pressure changes. Now, as I was listening to the presentation before, I would like to sort out certain myths about ultrasound. One myth which I heard was that ultrasound cannot detect small lesions. Lesions like 5 millimeter cannot be detected in ultrasound. Actually, on the contrary, transvaginal ultrasound has got a higher spatial resolution as compared to MRI, and MRI actually has a higher contrast resolution. So if you want to see smaller lesions, we are actually much better with ultrasound, provided we do a transvaginal ultrasound, than MRI. Of course, we cannot deny that MRI is better when it comes to mapping of lesions, especially when the uterus is very large and out of field of view of transvaginal sonography. Now, people believe that only ultrasound is operator dependent while MRI is not, which is not true because both the modalities depend on the reader's experience and expertise. So do not lose faith in ultrasound. And remember that most cases of AUB, abnormal uterine bleeding, can be easily and accurately diagnosed by skillful transvaginal sonography. And I will try to convince you about this in the next few slides. Now, before I talk about endometrial pathology, it is good to speak about this paper, which was published more than 10 years back, which gives us certain terms and definitions as to how we should describe an endometrial pathology, so that whether you describe it in at your place or whether I describe it at mine, we end up using the same terms and understand each other. Now, this is a very big paper, and I will just try to be very brief, give you a bird's eye view. So whenever you see the endometrium on grayscale, we can describe it as having a uniform echogenicity or a non-uniform echogenicity. Now, if it is uniform, that is homogeneous in appearance, the echogenicity can be hyperechoic, that is, it can be more white than the adjacent myometrium. It can be isoechoic, that is, the echogenicity can be same as the adjacent myometrium, or the endometrium can be hypoechoic, that is darker than the adjacent myometrium. So these are the terms that we use to describe a uniformly echogenic endometrium, that is hyper, iso, or hypoechoic uniform. When it is non-uniform, as you can see in these pictures, it is heterogeneous or non-homogeneous. So there are areas which are whiter, areas which are darker, areas which are anechoic, these are cysts. So this is what we describe as non-uniform echogenicity. The importance of this description is that based on this appearance, our diagnosis varies. Now, after looking at the endometrium, we've seen it on grayscale, we've measured it. The next thing that we do is look at its border or its junction with the myometrium. So here, if this is the endometrium, which I will say is non-uniform because I do see these hypoechoic areas in this predominantly echogenic endometrium, this would be the endomyometrial junction. So the junction of the entire endometrium with this myometrium would be the endomyometrial junction. And as you can appreciate, it is quite regular and well defined here. So this is a regular endomyometrial junction, whereas here you cannot really differentiate where the endometrium ends and where the myometrium begins. So this is what we call as an irregular endomyometrial junction. And then this is an interrupted endomyometrial junction when something is suddenly jutting at the endomyometrial junction. So at this part, you can see the endomyometrial junction well, but towards the fundus of the uterus, there is a sudden interruption. So these are the three terms that I use to describe endomyometrial junction. Coming to Doppler, it's always recommended to use something known as power Doppler when doing transvaginal sonography because it is more sensitive to flow than the routine color Doppler. So if you put on Doppler on a particular lesion or even on the endometrium, it can be scored subjectively. So if there is no flow, you give a score of 1. If there is mild flow, it is 2, moderate 3, and intense color would be 4. Similarly, if you see a blood vessel going from the myometrium into the endometrium, it will depend on how it appears. So this is what we call a single vessel. That single vessel can be branching. So this would be a single branching pattern. Then there can be multiple vessels, but they are coming from one particular area, so multiple focal. Or there can be multiple vessels, but coming from different areas, so multiple multifocal. Then the vascularity can be scattered, that is, it's just in the endometrium, but scattered. Or there can be this circular type of vascularity, which we all know is quite specific for a leiomyoma. Now coming to endometrial polyp. We understand that endometrial polyp is an abnormal growth which contains endometrial glands, stroma, and blood vessels, and projects from the endometrium, grows from the endometrium. It's usually a benign condition, and it's seen in women of both reproductive and postmenopausal age group. Majority are located in the fundus, but of course they can be situated anywhere where the endometrium is. Now let us come to the grayscale features or the appearance on black and white ultrasound. So I hope you can appreciate this is the entire endometrium. It actually has a trilaminar appearance. This is the outer bright layer, middle dark layer, and the innermost echogenic layer again. This is the myometrium. And what you appreciate here is this uniform hyperechoic lesion within the endometrium. It has well-defined margins, and you can see that the endomyometrial junction is regular. So at all the sides, you can see the endomyometrial junction is regular. So these are the characteristics of a typical endometrial polyp. But sometimes, especially in the postmenopausal age group, the polyp can have a little non-uniform appearance with presence of tiny cysts within it. So this is the classical appearance of the polyp. Another grayscale feature is presence of a bright edge. As you can appreciate, sometimes this interface of the polyp with the endometrium gives this bright edge to the polyp. This white thin line that you see is the bright edge, which can be seen in endometrial polyps. Coming to color Doppler. Now, if I were to switch on color Doppler, what happens? Typically, polyp shows a single feeding vessel, as you see here, going from the myometrium to the endometrium. This vessel may or may not branch within it. So that is what, the importance of using standardized terms, which I described earlier, because these are the features which will help you in identifying a polyp on transvaginal ultrasound. Again, this is another image with a polyp, but in this case, there is presence of fluid in the endometrial cavity, as a result of which this polyp is outlined nicely. So again, you see a well-defined, uniformly hyperechoic lesion. Note that this polyp is in the lower body and not in the fundus, which is a more common site. You can appreciate its bright edge. And if I would switch on color Doppler, there would be a single vessel going from the myometrium into the polyp. Sometimes we can instill saline within the endometrial cavity, as we've done in this case, and that helps to bring out the polyp better. Again, a well-defined, uniformly hyperechogenic lesion, and you can see that the endomyometrial junction is regular. There is no issue in that. Now, when we see a polyp, if we want to see whether it is sessile or pedunculated, all that we need to do is compare the size of the base with the maximum size of the polyp. So if the ratio between the maximum width of the polyp is less than 50% as compared to the base of the polyp, then it would be a sessile polyp, it would be a pedunculated polyp, as you see. Basically, if the base is narrow, it would be a pedunculated polyp. But in this case, what happens? If you see here, this is a sessile polyp because the maximum width of the polyp, as you see here, and that of the base are almost equal. So this is a sessile type of endometrial polyp, which is brought out better when we instill saline in the endometrial cavity. Now, this is a video, and I would like you to have a look at this clip. This is a grayscale image initially. So can you appreciate as I move? This is the endometrial cavity. This is the endometrium. And if you appreciate that this is this echogenic lesion, which is actually bulging from the endometrial cavity into the cervical canal. I know this is the cervical canal because I can see Nabothian follicles here. You can appreciate this lesion real time. This is uniformly hyperechogenic. And if I switch on color Doppler, I can see a feeding vessel going into this lesion, which is bulging in the upper cervical canal. So though this is an endometrial polyp, it has extruded into the cervical canal through the internal os. And therefore, whenever you see a lesion in the cervix, it is advised to switch on color Doppler so that you can follow this feeding vessel and identify whether the lesion truly belongs to the cervix or it belongs to the uterus. Because depending on where the origin of the lesion is, it would either be in the cervix or in the endometrium. As you see here, this is actually an endometrial polyp in the cervix. Now, sometimes there can be other things which are present in the endometrial cavity and mimic a polyp. For instance, you might think that this is a polyp, but actually this is just presence of fluid in the secretory phase. In the secretory phase of the menstrual cycle, when the endometrium is very thick, if there is some fluid, the surface of the endometrium is not smooth. Sometimes it is thrown into folds. And because of these folds, you might mistake it for a polyp. So that's why it's recommended that when you're looking for endometrial pathology, especially polyps, you assess the endometrium between day 4 to day 6 of the menstrual cycle, when you're not likely to have this appearance. Because if you were to look in the secretory phase, you might mistake a polyp. You might mistake the normal endometrium for a polyp, or its echogenicity may be similar to that of the surrounding endometrium, and you may not be able to appreciate it. Then endometrial hyperplasia can also have a polypoid appearance, as you see in this image. In this image, you see this hypoechoic lesion, which is protruding into the echogenic endometrium. So this is a submucosal fibroid, because as discussed, fibroids are dark as compared to the endometrium because they arise from the myometrium. So this is a submucosal fibroid. You should not confuse it with an endometrial polyp. And sometimes in the menstrual phase, especially if you're seeing when the patient is bleeding or having a lot of passage of clots, you might actually see a blood clot and think that it's a polyp. How you can differentiate it is that if you see on grayscale blood clots, and especially if you ask the lady to say push or do a Valsalva, you might see the blood clot moving, or you can press upon her lower abdomen gently and you might see movement of this clot within the cavity. That is the advantage of ultrasound, which MRI doesn't give, that you can see things real time. And if you will switch on color on this thing, because it's a blood clot, it will not show any feeding vessel, which is seen in polyps. Now from polyps, we move to a malignant entity of the endometrium, the endometrial carcinoma. And I'm sure you're all aware of the risk factors which predispose an individual to endometrial carcinoma. So I'll just speak about the ultrasound appearance of endometrial malignancy. So in a patient who has some kind of a menstrual issue and risk factors for endometrial cancer, you would suspect the same on ultrasound when you see a thick endometrium. So in a lady with postmenopausal bleeding, up to 4 millimeters of endometrial thickness, we need not sample, but anything above 4 millimeters or more needs further sampling. Now, endometrial cancer can have a varied appearance. Even a uniformly hyperechogenic, that is a uniform bright endometrium, can have a focus of endometrial carcinoma. And of course, the typical high risk or a high grade endometrial carcinoma would be non-uniform in echogenicity. So it will be heterogeneous. The endomyometrial junction in low risk endometrial cancers can be regular, whereas those in high risk endometrial cancers, which have a higher chance of recurrence post-treatment, tends to be irregular. Also, the color score can vary depending on whether it's a low risk or a high risk endometrial cancer. And so can the blood supply. So let us see what are the features of a high risk endometrial cancer. As I said earlier, a heterogeneous echogenicity. So if you have a look at this uterus, you can actually not measure the endometrium quite well. You don't know, if somebody was to ask you to measure the endometrium, you would not know exactly what is happening here, because this is a very heterogeneous, thickened kind of endometrium, and there is irregular endomyometrial junction. So as a result, it becomes difficult to measure the endometrium, and this is what a high-risk endometrial cancer looks like. When we switch on PAR Doppler, as we have done here, because this is a condition with large amount of neoangiogenesis, there is intense vascularity, and we would give this easily a color score of 4. So higher the risk of the higher the grade of endometrial cancer, more is the vascularity, more heterogeneous or dirty looking the endometrium and irregular the endomyometrial junction it is. Also, you can see that the blood vessels are growing into the endometrium from all corners. So you have these multiple multifocal vessels, unlike what I showed in a polyp where you see a single vessel. So this again is a pointer for endometrial malignancy. Now, this is also a case of endometrial cancer, but a low risk type of cancer. Here you can appreciate the difference from the previous image. The endometrium is more uniform, it is hyperechogenic, the endomyometrial junction is regular. And the vessel, they're not as many as were seen here. You can see multiple vessels here, but they are not as numerous and as irregular as was seen in the previous case. So vascular, if I were to give this a vascular score, probably I would give it a vascular score of 2 or 3. So low risk cancers tend to be more innocuous looking as compared to high risk cancers. And hence we must keep in mind that just because an endometrium looks uniform and thick doesn't mean that we can exclude cancer completely. Coming to myometrial pathology, which can lead to abnormal uterine bleeding. First, I would discuss adenomyosis. As we all know, adenomyosis is proliferation of endometrial glands and stroma in the myometrium. It has 2 types. It can be diffuse, involving the entire uterus, or focal. Now, what do we see? These are the various signs that we see on ultrasound, and let us try to see them in images so that we understand them better. Before I talk about or I show the images of adenomyosis, I just want to draw your attention to the Musart features of adenomyosis. This is again a set of terms which have been coined so as to describe myometrial lesions. And it would be a good idea to have a look at this paper so as to understand how to describe myometrial pathology on ultrasound. Now, what we need to remember is that according to the recent guidelines, these are the 3 criteria that must be present if you have to confirm the diagnosis of adenomyosis on ultrasound. These include presence of cysts in the myometrium, number 2, hyperechoic islands in the myometrium, and third, presence of echogenic subendometrial lines and buds. So these are the characteristic or hallmark features of adenomyosis. On the other hand, these features that you see here are something that should make you suspect adenomyosis, but just on the basis of these features, you cannot come to a diagnosis of adenomyosis because some of these features can be present due to other conditions as well. So just presence of asymmetrical myometrial thickening, that is if one part of the myometrium, say the posterior myometrium, looks thicker than the anterior, is not enough to make a diagnosis of adenomyosis. You should have at least one of these direct features to make a confident diagnosis of adenomyosis on ultrasound. Similarly, just fan-shaped shadowing is not enough. Again, we need a direct feature to confirm the diagnosis of adenomyosis. In diffuse adenomyosis, the uterus has a globular appearance, but this globular appearance can also be seen in certain other conditions and hence by itself is not diagnostic of adenomyosis. Vascularity, adenomyosis tends to show blood vessels coursing through it. And of course, we can have an irregular junctional zone or the endomyometrial junction in adenomyosis. So once you see an irregular endomyometrial junction, start looking for these signs if you're not suspecting an endometrial malignancy to rule out adenomyosis. Now coming to the direct features. First, we said myometrial cysts. Now cysts are fluid containing lesions, so they appear black on ultrasound. These are cysts. Now see where the cysts are. This is a longitudinal or a sagittal section of the uterus. This is the endometrium, this echogenic structure. So this is the myometrium. And these are cysts within the myometrium. So number 1, myometrial cysts, first direct feature of adenomyosis. Second, I said hyperechoic, that is white islands in the myometrium. So these white areas or hyperechoic areas that you see in the myometrium are what we call hyperechoic islands. Third, we said echogenic subendometrial lines and buds. So subendometrial means below the endometrium. So if this is the endometrium, these echogenic things that you see here are the subechogenic endometrial buds. Why do these appear? Because these are nothing but the endometrial tissue, which is growing within the myometrium. So the pathology helps us in understanding why the sonographic appearance is such. So these are just endometrial tissue, which is growing in the myometrium and giving this appearance on ultrasound. These are the indirect features, which should make you think about it, but then you have to look for direct features. So this is what a diffusely enlarged uterus looks like in diffuse adenomyosis. This is the cavity with minimal fluid. So not only is the uterus enlarged, but you see these multiple hyperechoic islands distributed throughout the myometrium. So direct feature. When the involvement is relatively focal, we call it focal adenomyosis or adenomyoma, as you see in this case. So it would involve just one wall of the uterus and not involve the uterus as a whole. Then another sign is the fan-shaped shadowing. So as you can see, we can appreciate these areas of shadowing from the myometrium. This is what we call as the fan-shaped shadowing, these dark areas. But in addition, you appreciate the direct signs which are more important, that is myometrial cysts, as well as presence of hyperechoic islands in the myometrium. A term which has been described or used to describe fan-shaped shadowing is this rain in forest sign. So just like it kind of resembles how rain falls in the forest, so this sign has been used to describe fan-shaped shadowing. Then intralesional vascularity, here you can appreciate there is this focal hyperechoic area in the anterior myometrium. These are all hyperechogenic islands here, and the endomyometrial junction is also ill-defined. If we switch on Doppler, we can see that this area has translesional, intralesional vascularity. There is hardly any vascularity in the same settings in the posterior myometrium. This is just a focal adenomyoma with translesional vascularity. Then 3D can also be used to show the endomyometrial junction better. As you can see in this image, we use the coronal image to see the junctional zone or the endomyometrial junction. The normal junctional zone appears as this regular hypoechoic line around the endometrium. In case of adenomyosis, because the endometrium is growing into the myometrium, we can appreciate these echogenic lines and buds, making the junctional zone irregular and disrupted, as you see in this image. So this is a milder degree of adenomyosis, whereas in this case, there is extensive disruption of the endomyometrial junction because of growth of the endometrial tissue into the myometrium. Coming to the next common myometrial pathology, that is fibroid. It's a benign tumor which is composed of smooth muscle cells and connective tissue. And that is why it has the typical appearance which it has on ultrasound. Fibroids tend to be well-defined because they have a capsule, and they are hypoechoic because usually muscle connective tissue is dark on ultrasound. They are relatively homogeneous, but again, they can be heterogeneous. They can be round or oval. They are solid lesions, and they can show shadowing. The shadowing in fibroids can be fan-shaped, like we saw in adenomyosis, or there can be shadowing at the edges of the fibroid. There may or may not be calcification. When we switch on color Doppler, typically we understand that fibroids show peripheral vascularity, but that is not always. Sometimes they may not show vascularity, and at other times they might actually show a lot of intralesional vascularity, just like adenomyosis. So just based on the Doppler findings, we cannot differentiate an adenomyosis from a fibroid. We have to take actually first the grayscale picture into account and then use Doppler as an add-on. Now coming to the typical appearance of a fibroid in ultrasound. As you can see, this is a very well-defined lesion seen in the myometrium. You can appreciate the endometrium displaced by this well-defined, predominantly hypoechoic lesion, but you can see that it is not that homogeneous. There are bright areas, so it's a heterogeneous, but predominantly hypoechoic lesion. We can appreciate that when we've switched on color, it shows circumferential, but there is some mild. So if I were to give it a score, maybe a score of 2, mild intralesional vascularity is also seen. Sometimes fibroids with this grayscale appearance can show intense vascularity as well. So one must not go away from the diagnosis of fibroid just because there is intralesional vascularity. If it is a well-defined lesion, hypoechoic on grayscale, even though if it has high vascularity, it will still be a fibroid. Then, as I said, there can be fan-shaped shadowing. We know how fan-shaped shadowing looks like now. This is what we call as the edge shadowing. So this is the lesion, this is the fibroid, and we can appreciate shadowing coming from its edges. Then fibroids can have very variable appearance, and sometimes we might actually get confused as to whether they are truly benign lesions or malignant based on their appearance. This is because of various kinds of degeneration which can occur and give a heterogeneous appearance. So these are both examples of fibroids, but you can see how atypical their appearance is because of presence of cystic change within them. So sometimes fibroids can have an atypical appearance, and in this case, you might just have to work with a differential diagnosis rather than giving a clear-cut diagnosis of fibroid, and may even have to resort to other complementary imaging modalities like MRI. Now, this is another example of a fibroid, but as I told you, normally fibroids are hypoechoic or darker than the adjacent myometrium. In this case, it is brighter. Why? Because this fibroid has fat within it. So sometimes fibroids can have this uniform echogenic appearance, but remember, this is not a polyp, it is a fibroid because it is in the myometrium. So do not confuse it with a polyp because it's separate from the endometrium. This is a lipoleiomyoma, a fibroid containing fat. And actually, this is another fibroid. How do we know? Because we see this peripheral calcification with dense posterior shadowing. So when fibroids have this thick peripheral calcification, the shadowing behind the calcification can obscure the fibroid and give this appearance. So this is a calcified fibroid, and this is a fibroid containing fat in the same uterus. Now, based on their location, fibroids can be submucosal, intramural, or subserosal. And we all know that submucosal fibroids tend to be more symptomatic because they are growing towards the cavity. Now, FIGO has provided a classification based on the location of fibroids and their relationship with the endometrium as well as with the serosa. So the types 0, 1, 2, and 3 are now termed as submucosal fibroids because, as you can appreciate, all of them have some relationship with the endometrial cavity. Type 0 are the pedunculated ones, which are protruding into the endometrial cavity. But how you will differentiate it from a polyp? Remember, a fibroid will be hypoechoic, whereas a polyp of the endometrial cavity would be bright hyperechoic. Type 1 fibroid is one when more than 50% of the fibroid is within the endometrial cavity. In type 2, 50% or less is seen within the endometrial cavity. And type 3 fibroids, which were previously termed as intramural fibroids, but now come under submucosal, are those which are present totally within the wall, but just touch the endometrial cavity, as you see here. Now, type 4 are the purely intramural ones, which neither touch the serosa nor the endometrial cavity. And then we have 5 to 7, depending on their relationship with the serosa. So just like the relationship with the endometrium, if less than 50% or equal to 50% is touching the serosa, it is type 5. Type 6, when more than 50% is bulging out of the serosa, and type 7 would be a pedunculated subserosal fibroid. Type 8 is reserved for those which are present in the cervix or atypical ones like parasitic fibroids or a broad ligament fibroid. Then there is something known as hybrid fibroids. These hybrid ones are those which have a relationship with both the serosa as well as the endometrial cavity. So they are given this number 2/5 because they have features of type 2 as well as type 5 fibroids. So this is how we map and classify fibroids both on ultrasound as well as MRI. So now let's have a look at this image of the uterus. First, let's identify this is the endometrial cavity with presence of fluid within it. This is the endometrium, which is thin echogenic. And this lesion, which has been measured, it is hypoechoic, protruding into the endometrial cavity, covered by the endometrium. This is a submucosal fibroid. And if we were to give it a FIGO type, which type would it be? If you can see, less than 50% or almost 50% of it is protruding into the endometrial cavity. So this is a FIGO type 2 submucosal fibroid. On the other hand, what about this lesion? Again, this is a well-defined round hypoechoic lesion, but its location is in the cervix. It's in the cervical lip. You can see how close it is to your transvaginal probe. So this is not a uterine, but a cervical fibroid. And of course, cervical fibroids are phagotype 8. Then 3D ultrasound also has a role in fibroids. Just as we can get nice coronal images in MRI to show the relationship of fibroids with the cavity, similarly, by using 3D ultrasound, you can appreciate, you see this well-defined fibroid protruding into the cavity, but you are not sure from which wall it is arising and how it is displacing the cavity. So if we were to take a coronal image by using 3D ultrasound, we could show the exact relationship that the fibroid is in the right lateral wall and is displacing the cavity to the left. So 3D ultrasound can help in fibroid mapping as well. Now, we know that fibroids can not only have an atypical appearance on ultrasound, but they can also be present at unusual sites. There are case reports of fibroids having been seen in these areas. And also there are certain unusual presentations of fibroids. You can see multiple leiomyomas studding the peritoneal cavity. There can even be something known as benign metastasizing leiomyomatosis when we see implants of fibroids in the lungs. So fibroids can have an unusual appearance within the uterus, or they can be present at unusual sites as well. Now, this is a table which summarizes the differences between fibroids and adenomyosis. And I'm sure by now you understand that fibroids are well-defined, hypo to hyperechoic lesions with edge or fan-shaped shadowing. To peripheral, but not always, they can show intralesional vascularity. And in fibroids, the junctional zone is regular, or it can be interrupted if a submucosal fibroid is bulging. Then we come to myometrial malignancies, which can be a rare cause of uterine bleeding, but we still need to be aware of their appearance on ultrasound. Most sarcomas of the uterus, that is, which arise from the myometrium, arise de novo. Rarely, 0.1% can arise from previous fibroids. The types of sarcomas that we can see in the uterus include leiomyosarcoma, endometrial stromal sarcoma, and undifferentiated sarcomas. They are usually seen in elderly women, and most patients with sarcomas are symptomatic. They would either have vaginal bleeding, pain, some kind of a symptom. On ultrasound, as expected, since they are malignancies which have hemorrhage, necrosis within them, the sarcomas would have a heterogeneous kind of appearance, dirty-looking lesions as compared to fibroids. They can have cystic areas, ill-defined margins, and increased vascularity because of neoangiogenesis. A very important feature is that sarcomas never have calcification or shadowing from them. So if you see a myometrial lesion, which is heterogeneous, ill-defined, vascular, and there is no calcification or shadowing, you can be more sure that it might be a sarcoma. In fact, a recent study done on sarcomas, a large number of sarcomas, has shown that actually size is not that reliable. Even sarcomas can be as small as 7 mm, and of course, they can be huge as well. So size per se cannot take you to a diagnosis, though larger the lesion is, more suspicious you can be. Also, you would think that since it's a malignant tumor, you cannot have free myometrium around the sarcoma, but that is not true. Free myometrium has been seen in as many as 75% of sarcomas in this study. Also, as we expect, sarcomas tend to be inhomogeneous. They have irregular margins, unlike fibroids, which are more homogeneous with regular margins. And of course, they would have more intense vascularity because of angiogenesis. Most sarcomas do not have calcification and shadowing. They tend to have cystic areas, which actually correspond with areas of necrosis. So this is what a leiomyosarcoma looks like. As you can appreciate, this is a lesion in the myometrium. It is heterogeneous, and it's very difficult to identify where its margins end or begin. And when we switched on color Doppler, we can see intense vascularity. It's 3 to 4 color score vascularity. So this was a case of a leiomyosarcoma. Now, I'm concluding here to show you a difference between fibroid and sarcoma. This is what a typical fibroid looks like, a well-defined hypoechoic lesion, whereas sarcomas tend to be more heterogeneous. You see cystic areas within them, as you see here. So if you see such a lesion, you will always keep a differential of a sarcoma in mind. However, this may still turn out to be an atypical fibroid. So one can never be actually 100% sure in ultrasound. But whenever you see something atypical within a fibroid, it's always good to raise a suspicion of sarcoma so that we don't miss out on this condition. With this, I come to the end of my presentation. I hope I've been able to show you certain common endomyometrial causes of abnormal uterine bleeding. And I hope you're convinced that actually transvaginal ultrasound is a good and, of course, the first line of imaging in such patients. It would be good if you could go through AITA and MUSA terminology yourself so that you understand how we use ultrasound to describe endomyometrial pathology. And I hope at the end of this presentation, you are able to recognize the sonographic appearance of common endomyometrial pathology. Thank you.
It was excellent. Excellent, Dr. Divya. Wonderful.
I'm so.
It was amazing. Very clear and superb message.
Thank you, ma'am.
Yes.
Chairperson, please.
Hello.
Yes, we can hear you.
Yes.
Unmute.
Yeah. Indeed, it was a very clear and precise presentation, right? And definitely, as you said, MRI has role, but ultrasound is the transvaginal ultrasound. There is no match to it, right? It had added advantage of real-time assessment, and though it is operator dependent, but definitely with exposure and with your experience, it can give far better information. Right? Definitely, in larger cases, we need MRI, but most of the times ultrasound, and you have very beautifully explained, and you had very good cases to validate your point. So thanks a lot.
Thank you, sir.
Dr. Rajeshri, you would like to say something? Dr. Rajeshri, ma'am? It was really Divya, Dr. Divya, wonderful presentation, and all the, meticulously organized your PPTs, your presentation, and you have simplified so nicely that I think all PGs, even anyone can think that you can do ultrasound regularly. It
Yes.
was nicely, very nicely, and they should know how to do ultrasound.
Yes, yes. Because they have a good clinical judgment already.
Yeah,
So
immediately.
it actually gives more information when somebody with a clinical knowledge does ultrasound.
Yes.
You took us to the movie inside the
Yeah.
endometrium. We all were in the endometrium for half an hour and seeing.
Yeah, we were just engrossed in that movie.
Thank you,
the
ma'am.
diagrams with the pictures were so explanatory. It was excellent to have you here.
Thank you, ma'am. It was my pleasure, and thank you again for having me. Thank you very much.
Anyone has any questions?
Ma'am, there's a question on how to assess mobility on ultrasound. So, ma'am, normally if we have to assess the mobility of any structure, we just push upon that structure with the ultrasound probe. So we normally inform the patient, and usually patients cooperate. If you can just push on that structure with the probe, or if it's accessible through the suprapubic, then we can ballot from there.
So I think you made it very much crystal clear to everyone that there are no questions for you.
I think I bombarded them with too much.
No, not bombardment. It was very calm, quiet. It's just like what Dr. Pragati said, we're in different zone. Wonderfully, you took us from different, all the levels, and your voice is so nice. Everything was just perfect.
Thank you.
It was from basics, no?
Yeah.
She gave basics of ultrasound to how to diagnose the very nice information. So
Dr. Mayuri, you also presented very nicely. And also you conducted very nicely, Beta.
I would like to thank our chairpersons, Dr. Rajshri Patil ma'am and Dr. Alad Moite sir for chairing the session. And I would like to invite Pragati Kalatkar ma'am for vote of thanks.
Oh, okay. I'm really, today I'm so happy and overwhelmed to have all these faculties here along with us and to announce that today is our 9th PG Star. Nagpur Obstetric and Gynec Society has started this PG Star where we are connecting not only to the PGs of Maharashtra or Vidarbha, but here we are connecting to PGs all over India and global PGs also. We have so many logins from overseas also. So, and the day by day, our program is gaining good, good momentum, and people are logging in huge number. We have reading of nearly 1,800 and 900 PGs logging in for our program. So all the success goes because of all the faculties who are selected and they come and do justice to our program. So at the onset, thank you, Dr. Sushma, President NOGS, for having such a wonderful idea of connecting to all the PGs. Then I'm thankful to Dr. Mayuri Bhagat, who have presented the case very well. Today's examiner, Dr. Surekha Taide and Dr. Swati Shiradkar were West. They have given a lot of insight into how to present and given good teaching to all of us. Session 2, that was Pearls of Wisdom, as Dr. Divya has done true justice to the topic, and she gave us a beautiful ride in the uterine cavity, and with her vision, we could see what we never used to see. Thank you so much, Dr. Divya Singh. Dr. Rajeshri Patil, she was there in the beginning. Thank you that GMC Gondi has been part of our this program, PG program. And thank you, madam, for chairing the session. Dr. Alad Moite, thank you for being with us today. And this program is not possible till our supports Dr. Anuja Bhalerao, Dr. Prachi Dikshit, and Dr. Bhakti Guzar. They take a lot of pains to make this program so perfect. Thank you, dear. And Master of Ceremony, Dr. Garima, you were so perfect in taking this crisp running. We started at 7 and we are just shutting down 10 to 9. So thank you, everyone. And last but not the least, all the delegates who have linked in, all the PGs, I wish you all the best. I hope you are learning a lot from this PG series. Keep attending our programs and spreading a word for it. Thank you so much. Good night.
Thank you. Good night, ma'am.
Yeah, good night. Garima, you really did very nice, huh?
Thank you, ma'am. Thank you.
Thank you.
Okay, thank you. Thank you. Bye-bye.
Bye-bye.
I am completing the meeting.